and welcome to another Pipe of Pearl. Today's Pearl, we're going to be looking at the cough. Now, cough itself is one of the most common medical complaints, accounting for around 30 million visits per year in the US. Now, up to 40%, believe it or not, of these complaints will actually result in a referral to a pulmonologist. A cough is an innate primitive reflex and acts as part of the body's immune response to protect against foreign material. Coughing is often associated with a wide assortment of clinical etiologies. What makes it worse is there's no objective tools to measure or clinically quantify a cough. As such, when you're going through evaluation of a cough, it's initially very subjective and involves a highly variable assessment. Now, given the vagueness of the symptoms and nature, along with the risk of some very nasty underlying problems, heavy impacts on the quality of life, and the lack of objective tools, so all things pretty much lining up against you, if someone comes in with a complaint that involves coughing, an evaluation should be treated as important until you can basically rule in a benign source. So going further on with a few more key facts about coughing. Coughing can be quite significant. So it's one of the cardinal signs of chronic bronchitis. If someone has asthma, controlled or uncontrolled, it often involves the most common version of productive cough that you will find. A person may have a cough for many, many weeks after, making it seem far more insidious than it actually is, but it occurs post a general upper respiratory tract infection like the common cold, which links to postnasal drip, which is simply a buildup of mucus in the sinus that rolls down the back of the throat, causing irritation and swelling, which makes the person cough and have a post-infectious cough as well. That is the most common cause of a cough. So whilst it's easy to jump on the bandwagon and say it's postnasal drip, being the most common, you need to do a good investigation to see if it's not something else, which includes the looking for hemoptuous, so blood within the sputum, because that can occur most of the time from an upper respiratory tract infection. Then you have bronchitis or bronchiolitis, which is similar to bronchitis, but just with more mucus basically. TB is a very common cause, and cancers, whilst most people think when they cough up blood it's cancer, it actually only accounts for 4% of the cases. And then there's the 22% that people cough up blood for unknown reasons. Quite often they theorize it's because of violent coughing, a lot of pressure building up, causing micro tears in the trachea itself, therefore you get blood, and also association with the GIT and gourds and that sort of thing. So just when you're going through an examination for a cough, just do your due diligence. Okay, you do a good assessment that we'll go through in this lesson in order to hopefully find a mundane reason. But if there is something more sinister, you can start treatment or further investigations earlier. So let's break up this etiology. Now, the etiology of a cough, as mentioned, is very arbitrary. And the arbitrary classifications are based largely on the duration of the cough, which I know is not the best version of classification because all coughs start on day one, which means all causes at some stage fit into the acute category. But having said that, if a cough is presently less than 3 weeks, it's designated as acute. If it's present for 3 to 8 weeks, then it's subacute. And if a cough is persistent greater than 8 weeks, it falls into the chronic category. Now, the most common cause of your acute cough, as mentioned, is that acute viral upper respiratory tract infection causing that post-nasal drip. Okay, even though post-nasal drip is written in the chronic section, it's still the most common cause for the acute phase as well. So common cold, acute bronchitis, which is often caused by viruses, but can be caused by bacteria in about 10% of the cases. Other things that cause acute cough is obviously influenza, pertussis, early stages of pneumonia, rhinosinusitis, and you can get some sinister things like pulmonary edema, aspiration syndrome. Okay, so don't forget those larger, more emergency-based ones. And then you can also get the people that have COPD, but they just have an exacerbation of it. So COPD may be completely under control, not really coughing. All of a sudden they get an acute phase, which puts them back into the acute cough section. So just because the term is acute doesn't mean that it's actually not something that needs to be treated. Okay, so don't fall into the trap of feeling that an acute cough is nothing to worry about because it's designated purely by time. When you move into that subacute coughing, it's most commonly caused by that post-infection secondary coughing, which is caused by irritation of the cough receptors or unresolved bronchitis, sinus inflammation, things like that. Now, most of the time, acute and subacute coughs are self-limiting illnesses and typically require just your supporting measures, but you can find those sinister ones. Once you move into the chronic cough, someone comes in and says they've been coughing for greater than 8 weeks, that often involves a more difficult diagnosis. Not necessarily more sinister, but more difficult to diagnose. And these ones will typically require that referral to the specialist. Now, in some cases, the cough can be caused by psychosomatic reasons. However, at first presentation, psychosomatic reasons should never be used as a diagnosis because you really need to rule lots and lots of other things out, okay, which obviously includes things that are outside of the upper respiratory tract or the lower respiratory tract and can include gastroesophageal reflux disease, which can account for up to 40% of chronic coughs. And then you have asthma. It's not your typical asthma, it's caused by non-eosinophilic bronchitis and more like a parasympathetic pathway asthma as opposed to your immune-based asthma. You get post-infectious regions, as we talked about, people that are chronic smokers, lung cancer, and then you've obviously moved into more of your heart failure problems as well. Now, you also have things known as interstitial lung disease, which is a large group of disorders that cause progressive scarring and hardening of the lung tissue. Now, these often occur as a result of exposure to hazardous material. So this is where your classic asbestosis, silicosis, pneumonitis, and pseudocyanosis comes into play. It's that irritation causes really prolonged inflammation that turns into scar tissue, and that is often associated with where people work. So as you can see, massive list of potential diagnosis. So it's up to you to break down where it fits and how bad and debilitating the cough is as you go through your examination. But before we get there, we'll just have a quick chat about what an actual cough is. So cough, as you could imagine, is largely an uncontrolled protective reflex that's responsible for the mucoclearing of the airway. The reflex is characterized by the closing of the glottis apparatus with the subsequent increase in interthoracic pressure. This pressure often exceeds 300 millimeters of mercury, just for knowledge. This is followed by a very forceful expulsion of air through the glottis and the pharynx space and then out of the body. Given the forceful nature of the process, the velocity of that can exceed around 800 kilometers per hour. Okay, so that's pretty violent coughing. And that causes all the mucus secretions and everything to loosen from the wall and get expelled. So whilst the body physiologically uses a cough as a reflex and a protective manner, it's possible for this cough in normal physiology to create an unfavorable condition. So it's excessively annoying for the person to have to deal with. Now, when we look deeper down into the pathophysiology, the reflex of the cough is initiated by mostly chemical irritants in the peripheral nerve receptors within the trachea, brachial pass in the large airway, and all the way down to the distal airways themselves. These are also present in the pharynx, laryngeal, tracheal bronchial receptors, mostly respond to chemical, but also can be stimulated by mechanical. That's how you get that tickle in your throat. The chemical receptors are sensitive to acids, heat, and pretty much anything that fits into that capsaicin-like compound. We actually have capsaicin receptors that are initiated by it. Now, to make matters worse, these receptors that we're talking about, the neural sensory receptors, are actually located within the external auditory canal, on the eardrum itself, the postnasal sinus area, the pharynx, across the diaphragm, pericardium, the stomach, and every one of those receptors are capable of causing a cough reflex, which obviously opens up the possibility of differential diagnosis. So a nice easy one you could do is, as people are cleaning ears out, or if you're silly enough to use cotton buds and you're cleaning the ear out, it can actually induce a cough reflex from doing so, and that's the reason why. So when you go through the actual mechanics of coughing, pretty much divided into three overarching phases: the inspiration phase, the compression phase, and then the expellatory phase. During the inspiration phase, inhalation occurs, generating an increase in volume within the pleural space, and this volume is necessary for generating that air pressure to move out to actually be productive. If you didn't have this increase in pressure when you coughed, if you just sort of induce a cough yourself with no pressure, it doesn't actually clear the lower airways. That's done mostly by the compression phase, and that's marked by closing of the larynx and combined with a contraction of the muscles. We're talking intercostal, diaphragm, abdominal muscles, all leading to a net increase in this interthoracic pressure without actually any air movement involved. So you're pretty much getting a balloon, squeezing it really tight before opening the end. Now, the opening of the end is what's known as the expiration phase, and it's marked by the rapid opening of the glottis itself, resulting in a high volume of expiratory air coming out. The rapid airflow causes vibration of the pharynx and the larynx, which gives you that characteristic cough sound. Now, throughout the process, airway compression occurs, resulting in a net decrease in that interthoracic volume, and after exhalation, a rebound inhalation may occur because you're empty. And depending on the duration of the cough, it can obviously lead to fatigue and compensatory hypoxia as a result of not being able to basically have enough interthoracic pressure to cause gaseous exchange. So it can be quite debilitating, annoying, exhausting, and come with greater systemic symptoms. So the old cough that most people think is quite mundane does in fact involve a huge list of differential diagnosis, a very complex pathophysiological pathway, and the hidden dangers of being quite a significant disorder. So let's help try to break this down, try to ask a few subjective investigations, move into objective findings in order to narrow down the actual possibilities to do the best care we can for our patients. So starting as always with our subjective investigations, we've got to find out the event. Now most people, when they come into the clinic or come to see a clinician, they don't often come and say, I have a cough. They say they're not feeling well, they say they have a sore throat, they're congested, difficulty breathing, and then you find out later on that one of the associated symptoms is a cough. So you need to take all the symptoms and feelings into account from the person, because it's a big list. So we want to know if there's any associated symptoms. They want to know about the upper respiratory tract infection. We definitely want to know how long they've had this cough for, because that fits into those classifications we just spoke about. We want to know what sort of cough it is. Does it have an associated pain or burning sensation? We'll go into a few more characteristics of coughs, but just let the patient explain initially what the cough is like. Is it very, very tight around the chest? People complain of chest tightness and fatigue. Usually means they're coughing violently or have been coughing for a long time and in increasing intervals as well. We want to ask the patient's perception of whether or not they have shortness of breath also. Now, it's really the past history that you can get a good idea of what line of investigation you want to go down. So you want to see what sort of work the person does, what sort of environment they find themselves in, because that leads to your interstitial problems, leads to your natural irritants, but also leads to risks associated with contagion and spreading, that sort of thing. Want to know if they've travelled, increases the possibility of things like TB. So we want to know where they've been and what they've been doing. Social history can be important because things like confined areas, cruise ships, camping trips, all that sort of stuff can cause irritation and a cough. But we also want to know if they're a smoker because it increases the risks associated with coughing and also opens up the diagnostic pool. Animal exposure is an interesting one because of pseudokinesis, basically meaning the inhalation of organic material, but also there's a lot of animals out there that cause certain viruses that are indicative of having a cough as well. So just having that information can help build a picture of what sort of risk factors combine in with this person's cough. As we move into subjective questioning, we really want to know about the cough itself. So you ask the characteristics of the cough. Now, if the person says that it's brassy cough, it sounds literally brassy, then that can be things like trachonitis or bronchitis itself. So it's indicative of intrinsic pressure on the trachea as opposed to on the lungs. Now, barking cough is a laryngeal disorder, like laryngitis. When you get a croupy cough, it often comes with stridor that you'll find during your further investigations, and that's indicative of a laryngeal disorder as well, but you'll lead into croup, especially if you're dealing with children. Okay, croup's not really a thing for adults because their larynx is too big. Laryngitis for adults, croup for children. It's pretty much how they break it up. It's also a whooping cough. If it sounds more like a hoop, then you're obviously dealing with your pertussis. If it's painful, it can be tracheitis, which basically just means you've got swelling in the back of your throat, so you've got a sore red throat, but it can lead into left ventricular failure as well. Depending on the demographic you're dealing with, it can be one to look out for. Other characteristics that are really important to narrow down is timing. So when is this person coughing? If they're coughing at night, then you're dealing with, can be asthma, postnasal drip, chronic bronchitis, pertussis, that sort of thing. But if they're coughing on exercise, so when they're walking, then it's more of your chronic bronchitis, bronchiolexis, which is basically that increase in dilation of the bronchies as opposed to swelling, but comes with an increase in inflammation and thickening, and a lot of the times irreversible damage that can obstruct the airway. Okay, it's not bronchitis, it's bronchiolexis. So that's ones to look out for. And also you can have your gourds, which can bring on a coughing reflex when you're walking. Now, there are little tips and tricks out there that mean that a cough is associated with something else. Okay, one of those things is changing your position. So if you move around, and just by moving around it causes a coughing reflex, then that's bronchiolexis, and you can also have lung abscesses that cause that. If you're dealing with coughing post-meal, they can actually be caused by a hiatus hernia, okay, or a fistula, or even a diverticulum that's forming in the gastrointestinal tract. So whilst it's quite rare, if someone says that they cough around filling their stomach, then that can be obviously a red flag to go for further investigations, but that's generally the cause itself. If the cough is productive, we really need to narrow down what the patient means by productive, because remember, postnasal drip is the most common cause of a cough. So if the person describes the sputum or the phlegm as snot, then snot's snot. It's come from the sinuses and it's nothing really to worry about. A simple test you can do to find out where the productiveness is coming from is ask the patient, if they can, some people can't, to hock a loogie, and if they can successfully do that, chances are their productive cough is in fact not productive and it's just coming from the sinuses. If the person is able to cough up phlegm being mostly that cottage cheese-like consistency, then we're dealing with a productive cough. And we can ask characteristics of that, which is colour and consistency. So thickened, really thickened, is obviously worse than moistened phlegm. The amount of phlegm can be important as well, because normally we produce about 100 to 150 mils of mucus, but we don't actually cough that up. So when we start producing more than that, then the magnitude can be important. Now the colour is not really a telltale sign of anything, but it does lead to certain indications. So green or yellowy colour is more likely to be an infection. Pink, red, bloody, yep, that's usually one that you can't hide around, but that's associated with hemoptysis itself that we just spoke about. If you have white phlegm, then that's allergies. It can be allergies like asthma as well, and it can be a viral infection also. Charcoal, well, that's obviously charcoal. Now that's what it is. People that are surrounded by smoke, firefighters get it a lot, and obviously heavy smokers too. If the person comes back with brown, it's often good to see the brown, because that's probably the most sinister, the one that needs the best investigation out there next to the hemoptysis, but the one that's not as obvious, because it's more indicative of a chronic bronchial disorder. So when you get if someone's coughing up phlegm and basically it's not white or black, then it's best to send it away for a sample to see if it's bacterial in order to start the correct antibiotics. Now, we haven't finished our subjective investigations yet, because believe it or not, allergies and medications can also play a role in the coughing saga. The allergies has a link from your upper respiratory tract infection. So if someone has allergies, hay fever, rhinitis, sinusitis, that sort of thing, then obviously that increases the probability of postnasal drip and causing that irritant type cough. You can also get sensitivities more than allergies that bring on gastric reflux and therefore leading to more likely the cough being caused by GORDS itself. So medications, the most classic medication to cause coughing is an ACE inhibitor. So if they're on an ACE inhibitor and they're coughing and it moves into that chronic phase, then it's actually recommended to stop the ACE inhibitor and move on to something else. But other medications that can cause coughing is your aspirin, your beta blockers, calcium channel blockers, and inhaled steroid. And there are also certain classes of antibiotics like sulfonamides, erythromycin, and your aminoglycosides as well. So once you've finished all your subjective investigation, it's obviously time to move on to our objective findings. Now, there is not a lot we can do objectively, but there are things that are very important to tick off. Now, when you're doing your vital signs, the temperature is important. If someone has a temperature and a cough, it generally denotes that they're at a higher stage of infection, either viral or bacterial. So you couple that information with productiveness, non-productiveness, and you start getting a picture of what it could be. An increase in rest rate is a sign of compensation, as to as a low SpO2. Some people don't know that they're hypoxic in the early stages. So if they are, it obviously needs to be taken into account. and that goes hand in hand with an increased heart rate. Okay, signs of compensation of lack of oxygen. Lung auscultation is very important when you're dealing with a cough. Makes a difference between an upper or a lower respiratory tract infection, and I'll be doing a separate lesson on lung auscultation, so have a look out for that. Someone having a cough often involves a HEENT examination as well, including looking for lymphadenopathy, but that's pretty much the physical examinations done. From there, we move into more specialized examinations, which is our pathology. You can get certain rapid antigen testing kits for obviously COVID and influenza A, influenza B. So if you have them in the clinic, don't be afraid to use them. Blood tests can be taken. You can do general FBC, ESR, and something known as a respiratory pathology panel, which helps diagnose down what sort of virus they're dealing with a lot of the time. We want to take a sputum sample. If they've got a productive cough, and it's a real productive cough, don't send away mucus, you'll look like an idiot, okay? Then you'll want to do that. You want to get an MCS and a PCR. Okay, so you want to know if it's a virus, you want to know if it's a bacteria, you want to know what sort of antibiotics this person needs. If the person has associated shortness of breath, it's a good idea to do a spirometry. I'll be doing another lesson on spirometry and the findings. So again, have a look out for that. The reason I'm splitting these lessons up is because if I put them all in one, this lesson will be very, very long. And sometimes people just want to know how to do the examination as opposed to the entire consultation. Now, when you come to the decision of a chest x-ray, a lot of the time a chest x-ray is done for chronic cases, but it can be done for cases that aren't resolving to what you thought. So a person coming back in, you either have no idea, so you go for a chest x-ray, or it's bad enough, sinister enough consolidation that you want an x-ray, or it's been going on so long that they really need one by now. Okay, so that does happen in that diagnostic stage. Once we get all the data we need, we do an assessment. Now, I wish I had some easy lines for an assessment for you, but realistically, it comes down to your clinical understanding and clinical rationale for what you're dealing with. So ask yourself, is it acute, subacute, or chronic? If you're already at that chronic phase, try not to dismiss it so early. Coughing for 8 weeks is quite significant. So even though it may be mundane, everything you find, it may be worth passing it on to specialists just to see if they can find something that we couldn't, basically. Review what the cough was like. Are we dealing with a productive cough? Are we dealing with a cough that happens at night on exercise? Was there any sputum? That changes things. Can you, as an individual in your environment, treat this person, or should you refer or evacuate this? These are all questions you need to ask, and you base it off the data that you collect. Hey, that's the best I can give you for assessments. But we can go through some treatments and things that we can do. So education is very important, and cough etiquette is one of those educations. Now, if you remember, everyone walking around wearing masks, the reason people were wearing those masks had nothing to do with them inhaling particles or anything like that, because a lot of the droplets weren't big enough that were coming out. The point of the mask was to capture things that the patient was coughing out onto surfaces. So when you cough and you use your hand or you use your arm and you use your sleeve, you are projecting a whole bunch of droplets everywhere. So if you coughed on an uncovered environment, those cough particles will spread everywhere and they'll land on surfaces. People will touch those surfaces and then people will touch their face. And that's how this stuff is spread. It's spread by droplets. So cough etiquette, don't cough in your hands. Okay, that's just silly because you're going to touch everything else. Cough into your elbow, cough into your sleeve. I don't care. Wear a mask. Just stop the spreading of the droplet effect. That's what cough etiquette is all about. People are often concerned when they have musculoskeletal pain as associated with cough. Just explain to them that they're now using muscles more rapidly than they ever have and more violently than they ever have. So it's like doing a massive squat session, but for your chest. So you're going to get this pain. And just talk them through it. Let them know that they're going to be okay. This is what muscle pain feels like, that sort of thing, and they can take analgesia to help. When we move into treatments, there's obviously a whole list of treatments that we have at our arsenal. Now, the pharmaceutical world has latched on to the fact that a cough is extremely common and extremely irritating. So we have a whole array of over-the-counter medications. Huge array of mixing of decongestants and antihistamines and pain relief and all sorts of stuff, all mixed into one for your cough. Now, most of them, for most of the coughs out there, don't do anything at all but create a placebo. Patient comes in and asks for a specific drug, tell them what the drug is, give them some education, but if they still want the drug, give them the drug, free will and all, but a lot of the times they won't do too much. Giving an antihistamine can be helpful for rhinitis. That's only if it's caused by a histamine line as opposed to a bradykine line. So, a lot of the time they're not, which is why these studies that get done get swayed. So you can try antihistamines, you can try a decongestion, basically use what works for the patient and what helps the patient. But don't be surprised if, in fact, good old bed rest and time is really the only thing that fixes the patient's problems. When we move into things like cough suppressants are out there and they're designed to lessen the cough and blunt that cough reflex. Okay, that's what they're designed to do. It's very important to remember that a cough is the basic defense of the body's immune system. Decreasing a cough reflex may have detrimental impacts in recovery and how long the infection lasts. So there's an American College of Chest Physicians out there, and they released a set of guidelines that pretty much wants to ban the use of peripheral and central acting cough suppressants for the treatment of the cough. They're also on the bandwagon of discouraging all over-the-counter combinations that include a cough suppressant as well, because it is statistically leading to minor problems becoming larger problems like pneumonia because the cough was suppressed. Okay, so just keep that in mind when we're dealing with cough suppressants. Now, an expectorant is obviously used when there's a lot of irritations. So if there's XXX mucus secretions, then an expectorant can be good. Like a mucolytic that you can give, it can be quite an effective way to go. Antibiotics, we only give antibiotics based on the results of a sputum sample. Okay, it's not common to give antibiotics prophylactically unless somebody has signs of pneumonia and they're starting to move into that sepsis space. Pneumonia is a very common cause of sepsis, so if they have signs of sepsis, then you go down that line. Bronchodilators are used when the person has shortness of breath and has signs of restricted airway. So they can be given your salbutamol, your ibuprofen bromide, things like that in order to help increase the airway size whilst they recover and get more oxygen in, reduce the fatigue. If they have a GIT problem, you won't be diagnosing it on the spot, but obviously the treatment of that can be proton pump inhibitors, and it's recommended to actually go the highest dose of proton pump inhibitors you can until the cough is under control. But that is obviously a referral. Speaking of which, we're going to look at the patient and think about the restrictions. So the restrictions can be for the benefit of everybody else. These things can be very contagious. So consider isolating the individual until it passes, whether that's working from home, whether that's getting the hell out of the workspace so they don't infect anybody else, whatever it is. Let them know how to manage fatigue. Let them know that they will be fatigued, okay? More fatigued than they possibly will give themselves credit for. Okay, they may need an increase of water intake because coughing is actually quite taxing. So let them know and give them restrictions to suit. If the person can't breathe, probably doing a 10K run is not the best idea. So give them restrictions based on that. Think about the work that they have to do, the environments they have to be in, and whether or not a cough is a good idea in those work environments or those situations. If it's not, do something about them to look after the patient. Referral, all chronic cases. Realistically, easy rule of thumb, someone's been coughing for 8 weeks or more, refer it on, do the patient a favour, have a deeper investigation. If you think it's asthma and the person hasn't had asthma before and the asthma is not associated with any illness, so they've got asthma-like symptoms, then a good referral to start a good asthma plan can be an idea. Someone has signs of pneumonia, refer them on, hospitalisation can be needed. And realistically, if you're worried or unsure of the cause, trust your clinical judgment. If the person doesn't look well, looks more sinister than just an annoying little cough, then do the patient a favour, refer them on for further investigation and care. Well, that brings us to the end of the Pearl. Quite a long one, as you could imagine, because cough is quite a detailed subject. Just do yourself a favour, do the patient a favour. Someone comes in with an associated cough, expand your mind a little bit further that whilst it can be mundane and boring and very easy to manage, it can also be quite sinister, and it's your job as a clinician to do the detailed investigation in order to distinguish which is which. But until next time, take care.